I want to spend about the next 45 minutes or so talking about carbapenemase production. We've seen a ton in the literature around carbapenemase production, probably only exceeded by data on SARS-CoV at the moment. So I thought it would be worth some time really to talk about carbapenemase production, where we are in the science of understanding CRE, what its implications are, what its impacts are, and if we do decide to do screening, what technologies we should be using. So I've broken down our presentation today into 6 different areas. We'll first talk a little bit about the mechanisms of carbapenem resistance, and that becomes really important as we start to talk about the impact of CRE and CRE infections. It becomes equally important when we talk about screening for CRE and how we do screening for CRE. And it's also important as we start to think about what are those reservoirs of CRE? Where would we expect CRE to happen? We'll end the presentation with a few concluding remarks just to summarize what we've talked about throughout the presentation. But first, as a mechanism of general review, let's talk about the mechanisms of carbapenem resistance. And we can largely classify carbapenem resistance into 3 different groups. Those that we consider to be intrinsic resistance, or resistance that's always there, mutational resistance, as well as acquired resistance. So if we think about intrinsic resistance, the 2 most common mechanisms that we see associated with intrinsic resistance is permeability changes, so the inability to get a drug into the organism, lack of target, in other words, the drug doesn't have a place to bind, and we also can see general efflux pumps that actively pump the drug out of the cell. And when we think about intrinsic resistance, we really should be thinking about the classic gram-negative example of Stenotrophomonas multifida being resistant to all of our carbapenems. It's also important to note when we think about intrinsic resistance, this is generally occurring on the chromosome, making it very, very stable. Now, when we think about mutational resistance, this is really going to be random point mutations that happen. A point mutation that happens in the binding protein of a target, changes the target specificity. Again, these tend to be very chromosomal, so they tend to be a bit more stable, and they can affect broad classes of drugs, or they can be fairly narrow. The third class of resistance, or the third class of resistance mechanisms, are those that are acquired resistance mechanisms. And we can think about acquired resistance mechanisms as non-essential gene products that are produced with a specific function. And when we think about antimicrobial resistance associated with acquired resistance, classic example is the acquisition of a beta-lactamase. We've been dealing with beta-lactamases really since the introduction of the beta-lactams. We can also think about acquired resistance through quinolone efflux pumps, as well as through aminoglycoside modifying enzymes. One of the challenges with acquired resistance is these are often present on a plasmid. They're not always, but they're often associated with being on a plasmid. And when we have things that are associated and are carried on plasmids, it makes them much, much easier to transmit. So we're going to talk a bit more about carbapenem resistance throughout the talk today. We can think about the example of the emergence of KPC. We initially saw KPC emerge in Klebsiella pneumoniae, as the name would suggest, and it quite quickly transmitted from Klebsiella to E. coli, as well as through other members of family Enterobacterales. It's also important to note that when we have plasmid-based resistance, the resistance factor that you're interested in is oftentimes carried in a multi-drug resistance cassette, carrying multiple resistance genes. And these can also be on mobile elements, so they can jump from the plasmid to the chromosome and back again, really contributing to that transmissibility of them. Plasmid-based acquired resistance is one of the major contributors to extreme drug resistance and to primary drug resistance. So when we think about mechanisms and when we think about acquired mechanisms of carbapenem resistance, there are a number of different ways you can get an organism to become carbapenem resistant. And we can generally classify these into two different groups. We can classify them into the non-CP-CRE or non-carbapenemase producing CPE or CRE, and these can include things like efflux pumps, porin mutations, or a combination of an efflux pump and a porin mutation, along with another hydrolyzing enzyme like an AMP-C or an ESBL. So the AMP-C and the ESBL knock out the vast majority of our cephalosporins. We add the porin mutation or the efflux pump to actively pump out the carbapenem, and as a result, now we have a carbapenem-resistant organism. The second group that we can target are the CP-CRE, or the carbapenemase producing CRE. These are organisms that produce an enzyme that will actively hydrolyze, bind the beta-lactam, and inactivate it. And when we think about CP-CRE, one of the most important things that we recognize is that there are a lot of enzymes that exist, more than the common 4 or 5 that we often test for. So we commonly see things like KPC or Klebsiella pneumoniae carbapenemase. We see enzymes that are also less well known, things like IMI enzymes, GES enzymes. We can think about the OXA enzymes, and we can think about the metallo-beta-lactamases. So in all, for the antimicrobial susceptibility enthusiasts of the group, we can classify these into class A, class B, and class D beta-lactamases. Our common class A is KPC, our common class D is OXA48, and then we have our class B or our metalloproteases, things like NDM, VIM, IMP, as well as a number of less commonly encountered carbapenemases. Understanding the diversity of different carbapenemases is really important to developing a screening program because ultimately the test that you're going to use may not identify each of these carbapenemase types. And that may be okay depending upon the goal of your screening program. So for most commercially available screening tests, we look for KPC, we look for NDM, and then variable based upon the test, we might look for VIM, we might look for OXA48 or other OXA enzymes, and we may also look for IMP type enzymes. But at the end of the day, I want you to remember throughout the talk today that this all comes down to a definition. And you're going to see there are important outcome differences based upon what you define as a carbapenem-resistant organism, or a CRO or CRE, Carbapenem-resistant Enterobacterales. Are we interested in identifying those organisms with decreased membrane permeability? Are we interested in those that produce carbapenemase activity? What are we really interested in, and what are we going to define as the goal of our screening program? Now, as we start to think about screening for CRE and we start to think about the impact of CRE infections, the impact is quite great. And there are a number of studies that have looked at the impact of carbapenem resistance. Again, one of the first things that you have to think about as you start to think about carbapenemase production is just how common is this resistance in your geographical area. And this was very nicely summarized in a study by Mariana Castanajara from the JMI group, when they looked at the presence of carbapenemases across different regions of the United States. So for example, in the north central region of the US, this includes states like the Dakotas, Minnesota, Iowa, Missouri, the presence of carbapenemases is quite rare. In fact, in their survey, they weren't able to identify any carbapenemase producing organisms. In the region that I live within, which is the east north central region, the prevalence of carbapenemases is around 0.5%. In the Pacific region, California, for example, where our webinar is being hosted out of today, the prevalence is again quite low at around 0.3%. Now, for those of you that may be in the mid-Atlantic region, states like New Jersey, New York, Pennsylvania, you have a bit higher prevalence at around 3.5%. So again, one of the important things that we really have to think about as we think about the implications of CRE, as we make choices around what empiric antibiotics we're going to choose to have on our formularies. And as we start to develop screening programs, is just how often am I going to find this? And what's the risk of my screening program identifying a false positive? More about that in just a moment. We also have to think about what is the impact of multi-drug resistant infections to our healthcare institutions. And there are patient-based impacts and there are cost impacts that can happen. And in this study, you can see the impact of a general hospital onset healthcare associated infection is on average about $20,000 US. Now we can break that down based upon the type of infection that we may encounter. So if we look at two different studies, one published by Zimlickman and the other published by the Nonpartisan and Objective Research Organization out of the University of Chicago, you can see that by comparison among the healthcare associated infection types, CAUTIs are a relative bargain. Our catheter associated urinary tract infections will cost around $924 in the Zimlickman study and around $13,000 in the Norick report. By contrast to that, bloodstream infections, specifically central line associated bloodstream infections, will increase the cost of hospitalization by between $47,000 and $48,000 based upon the individual study that you may be looking at. And if we look at this from a Medicare perspective, this also results in substantial additional costs that may not be reimbursed by Medicare or Medicaid. So if we look at a Medicare specific study, so Medicare Part A, which is hospitalization costs, for patients that have a healthcare associated infection, you can see that for a urinary tract infection in this study, a catheter associated urinary tract infection will add about $6,000 in additional cost to a patient's hospitalization. But if we look at the ability to recover some or part of that cost, we only can recover about $2,000. So this is $4,000 in additional cost that is never reimbursed. Similarly, for a bloodstream infection, it adds approximately $15,000 in additional cost. But you can only recover about $8,000 in additional payment if you recover anything at all. So you have a net loss of $7,000 in each patient that develops a multi-drug resistant infection while in the hospital. So there is a substantial financial cost to the presence of hospital-associated infections, including CRE infections. But there's also a human cost to this process. And in a study published by McConnellville and colleagues in the journal PLOS One, they looked at 30-day infection rates among non-colonized patients that were colonized with ESBLs or extended spectrum beta-lactamases, and patients that were colonized with Carbapenem-resistant Enterobacterales species. And they compared the mortality in each of these different groups. So among non-rectally colonized patients, the 30-day infection rate was approximately 2.8%. If you were colonized with an extended spectrum beta-lactamase or a cephalosporin resistant isolate, your risk of developing infection within 30 days of a procedure was approximately 3.4%. If you were colonized with a Carbapenem-resistant Enterobacterales, your 30-day risk of infection jumps to 47%. And that's an increase in the odds ratio of about 10.8, which is a statistically significant difference. Beyond the risk of an infection, there is also the risk of increased mortality. So this study looked at the risk of 90-day mortality, and among non-colonized patients, that was about 50%. Among ESBL colonized patients, 90-day mortality was around 31%. And among Carbapenem-resistant Enterobacterales carrying patients, that risk of 90-day mortality was approximately 36%. So you can see the simple presence of GI colonization of CRE not only increases your risk of infection, but it also increases your risk of having a bad outcome. We also can look at what is the impact. So we can, well, let me back up and just say, we can see that there is a significant both financial cost and human cost to infection with CRE. And you might be starting to think now, well, why wouldn't anybody just start their own screening program for CRE? We can also look at what does screening do for CRE? And there are a number of studies that have asked this question. Richter and colleagues published in a review in 2017 in the journal Virulence a proposal on who should be screened. And they divided their patients of who should be screened into two different groups. Patients that should be screened weekly and patients that should be screened upon admission to an individual hospital unit. So among patients who should be screened on admission to the unit, this included patients that were being direct transferred to that unit from a long-term acute care facility, patients that were being transferred from another hospital, patients that were being transferred from a long-term care facility with a known CRE outbreak or known CRE presence, patients that were being directly transferred from a different ward within the same healthcare facility, patients that had a recent hospitalization, and recent hospitalization was defined as within the past 6 months, patients that had a functional dependency, so in particular, those that were incontinent, patients from countries with known high rates of CRE, and patients that were included as prisoners. Among those that they suggested that should be screened weekly, these included patients that are in a long-term acute care facility, patients in the ICU, dependent elderly patients in medical non-ICU wards, dependent post-op patients in non-ICU wards, hem-onc patients, and patients in wards with high colonization pressure. In other words, a lot of use of antibiotics. So this is who they would suggest we think about screening. Now, you have to ask the question, if we're going to develop a screening program for CRE, how big should that program be? In the first section of the presentation, we talked about the difference between a carbapenemase producing organism and carbapenem resistance. So this study, published by Tama and colleagues in the journal Clinical Infectious Diseases, looked at 14-day and 30-day outcomes associated with patients that had non-CP CRE, so non-carbapenemase producing CRE, and those that had carbapenemase producing CRE. They enrolled 83 patients, all with a known carbapenem-resistant bloodstream infection, and 37 of those were CP producing, and 46 of them were non-carbapenemase producing. So if we looked at 14-day mortality among the non-CP CRE group, they saw approximately 13% 14-day mortality, as opposed to carbapenemase producing CRE, mortality jumped to approximately 32%. So the odds ratio of dying as associated with carrying a carbapenem-resistant organism is approximately 3.2. They also looked at the risk of relapse, so the risk of developing a secondary infection with the same organism. Among the non-CP CRE, the risk of relapse at 30 days was only 8%, as opposed to the carbapenemase producing organism, the risk of relapse was approximately 38%, a difference that was statistically significant. So this study from CREs that are infecting patients with bloodstream infections would suggest that any screening program probably should be directed to at minimum detect carbapenemase producing organisms, because we know there's a bit lower risk of mortality as well as risk of relapse with non-carbapenemase producing organisms. In another study that looked at the impact of CRE screening, Yang and colleagues asked, what is my risk of developing an infection based upon the outcome of the screening program? So in this particular study, they looked at 706 hematopoietic stem cell transplant patients that were screened using a stool swab that was put into a non-enriched culture-based method. And we'll talk more about culture-based methods and non-culture-based methods in just a moment. And they defined a positive as any organism that was resistant to meropenem, ertapenem, or imipenem. So this study looked for both non-carbapenemase producing organisms and carbapenemase producing organisms. They divided their patients into 3 groups: those that weren't screened, those that were screened once before their stem cell transplant, and those that were screened on a continuous basis, weekly. So among the non-CRE screening group, as we would expect, nobody was identified to be CRE positive. Approximately 6 of the 311 people that were enrolled in this group developed CRE bloodstream infections. So 1.9% of the population developed a CRE bloodstream infection, and the BSI mortality was approximately 67%. But again, I would point out the fact that these are rather small numbers. In the second group, those that were screened once before their stem cell transplant, they identified 3 out of 200 patients that were colonized with CRE, so about 1.4 or 1.5% of their population. And among that population, approximately 2% developed a CRE bloodstream infection. And their mortality in this particular case was approximately 50%, again, noting rather small numbers. In the third group, those that were screened on a continuous basis weekly, they have identified approximately 10.8% of the population that was carrying a CRE in their GI tract. 1 out of the 195 patients that was in this group went on to develop a CRE bloodstream infection, and none of those patients died. So this is left to ask us the question, why is there a difference? Why do we see improved outcomes when we use CRE screening? And the theory behind this is that if we know that a patient is colonized with CRE, we're more likely to look for it, and we're more likely to be much more aggressive in managing that patient's antimicrobials at the time a blood culture or other infection develops, and we're more likely to use a CRE covering regimen in managing that patient's infection. Now, we've talked about some important medical outcomes when it comes to developing a CRE screening program. But as healthcare providers, we're entrusted to care for the entire patient, not just their medical care. We also have to care for their emotional well-being. We have to care for their spiritual well-being. We have to care in addition to their medical well-being. So in a study published by King and colleagues, and this was published in the Journal of Clinical Nursing, they asked patients, what do you understand about screening for carbapenem-resistant organisms? And there were a number of themes that came out of this study. One of the themes that came loud and clear from patient feedback is patients struggle to understand what a carbapenemase producing organism is. They struggle to make sense of it. They don't understand what it means for, or why it means they're being cared for in isolation. So this is a real opportunity for us as healthcare professionals and as laboratorians to do a better job of explaining to people what this is. So as clinical laboratorians, we should be thinking about how do we communicate to our healthcare colleagues in telling them that a patient is CRE colonized and what that means. We may need to think about adding comments to our reports to indicate what these mean, to help our healthcare providers better understand this and to help our patients better understand this. Another theme that emerged from this study was carbapenemase producing organisms. When a patient is told that they're colonized with a CPE, they often develop a sense of blame, a sense of guilt, as though the healthcare system is telling them they're unclean, that they're dirty. And patients oftentimes worry about, what do I need to do to prevent transmission of this organism to my family that shares a house with me, to my friends? So they feel a sense of responsibility. So while there are some very, very pressing arguments in favor of CRE screening, we certainly do have to consider how we communicate results, and we have to consider how do we develop, or how do we relay this information to our patients so they understand the meaning and so that they understand why we're taking certain steps? We also have to consider what is the impact of putting these patients in isolation. And I thought this is a really interesting study published by Purcell and colleagues. And they did a meta-analysis of all studies evaluating patients' emotional well-being and its association with being in isolation. And in studies ranging from 1997 to 2016, almost universally, you will see that when we put patients into isolation, they develop a sense of depression. It's because they're not able to interact as effectively with their healthcare teams or their family members. The same study also looked at what happens to patients' anxiety levels. And again, over the same set of studies, almost universally, we see that when we put patients into isolation, they develop a greater sense of anxiety, which can be certainly harmful in helping patients to heal and helping them to improve their medical conditions. So I'm not advocating against the use of CRE screening in isolation, but just that we need to consider not only the medical implications, but also the implications on patients' emotional well-being as we start to think about screening for CRE and isolating patients if they're colonized with CRE. Now, the next thing that we have to do, if we've decided that we're going to develop a screening program for CRE, we have to decide what methodology we want to use to screen. And there are a lot of available technologies, and we'll review several of those today. Really, all of this begins with culture. So the initial CRE screening technologies that were developed was developed by the CDC, and it was a culture-based screening approach. So it used broth enrichment, followed by direct plating, followed by the administration of an antibiotic, or it could use a chromogenic medium. So in the CDC method, we take a tryptic soy broth and we add an ertapenem disc into that tryptic soy broth. We incubate our rectal swab or our stool specimen in the broth for 18 to 24 hours. And if the broth turns turbid, we plate this to a McConkey agar. And on that McConkey agar, we place an ertapenem disc into the first quadrant. Again, we incubate that for 18 to 24 hours. And any growth that emerges in that zone, we sample that growth, put it into another tryptic soy broth, this time with meropenem, incubate it for 4 hours, and then go on and plate that. And we look to confirm, is this a carbapenemase producing organism, or is it not a carbapenemase producing organism, using a test like the MSIM test. It's a very effective screening technique. It's important to note, to get to a preliminary CRE screen, so to get the first two steps done, you're talking about 48 hours in general. And that's only assuming that your screen is negative. If you have any colonies that are growing within that first quadrant or around the disc, to get to a confirmed CRE result, we're now talking about 72 hours, and that can be a fairly extensive delay in getting results back to the healthcare team and getting a patient into isolation. So there are a number of other approaches that we can think about. So we talked about the CDC method. There are a number of direct plating methods like chromogenic media, where we use the appearance of color together with media that's supplemented with carbapenem antibiotics, and we look for growth on this media. If we see growth, we can then subculture that plate to our TSB broth plus meropenem. We incubate it for 4 hours, and again, we use our same MSIM test to confirm whether or not this is a carbapenemase producing organism or not. We can also do the same direct plating using a McConkey agar plus an ertapenem disc, followed by our MSIM test to speed the results up just a bit faster. And not surprisingly, there have been numerous studies that have evaluated the performance of each of these different methods. One of the nice studies that was done that evaluated sensitivity of a number of these methods was published by Trish Simner and colleagues at the Johns Hopkins University in the Journal of Clinical Microbiology. They compared the performance of the CDC broth-enriched culture method to direct McConkey plating to a chromogenic media known as CRE CARBA, as well as to a direct CPE or Carbapenemase producing Enterobacterales screening test. So in this particular study, they separated Carbapenem-resistant organisms, and they also identified Carbapenemase producing organisms or CPOs. Among Carbapenem-resistant organisms, so this is the broader group that includes not only the Carbapenemase producers, but also the non-Carbapenemase producers, they found that the CDC method was approximately 55% sensitive as compared to direct McConkey agar plating, which was approximately 95% sensitive. And this was also compared to the CRE CARBA, which was approximately 75% sensitive. Among Carbapenemase producing organisms, they found the CDC approach was only approximately 40% sensitive as compared to the direct McConkey agar, which was 80% sensitive, and the Czech direct CPE screen test, as well as the CRE medium, were both 100% sensitive at identifying Carbapenemase producing organisms. Each of these approaches displayed reasonable levels of specificity, but it really left us asking the question, why the lower sensitivity with the broth-enriched technology? Well, there's a couple of reasons why. First, we can worry about overgrowth of Pseudomonas and other non-lactose fermenting ertapenem-resistant organisms. But there are other reasons that we'll get to in a slide or two that we really have to think about if we're going to use a culture-based screening technique. In another study, and this is going back to the Richter study, they summarized a number of different studies that had evaluated CRE screening methodologies from rectal or perirectal swabs. They looked at the CDC protocol. They looked at the McConkey agar with carbapenem disc direct method. They looked at McConkey agar with imipenem, McConkey agar with meropenem. A number of different chromogenic medium as well were included. And they again found slight differences in sensitivity. So for the CDC protocol, their sensitivities were reported anywhere from 65 to 98%, with specificities ranging from 49 to 100%, depending upon the individual study. Now, it's important to note, in the vast majority of the studies that they looked at, there was a predominance of KPCs that were enrolled in those studies, with only a handful of mechanisms like VIMS or OXA48. Using the direct McConkey agar approach with either a generic carbapenem disc, imipenem, or meropenem, they again found improved sensitivity ranging from approximately 75% to 96%, and again displayed very good specificity, in most cases ranging from 73 to 100%. Interestingly, in this study, looking at McConkey agar direct plating with imipenem, one study did demonstrate approximately 31% specificity, so a lot of breakthrough growth. And again, among the chromogenic media, there was some variation in performance, ranging from sensitivity of 57.6% to 100%, really dependent upon what carbapenemases you're looking for and what carbapenemases were included in the individual studies. But again, we're left with the question, why? Why are cultures not performing better? And the answer to that question is, it all comes down to biologic variability. Unfortunately, in biology, most things are not constant. And in antimicrobial resistance, the same is true. We have variable expression of these carbapenemase resistance mechanisms. So in this particular study, the authors looked at the MICs of a number of KPC, NDM, and OXA producing carbapenemase producing organisms. The interesting thing that they found was when they looked at the MICs to meropenem among all CPCREs, approximately 20% of the strains that they enrolled in their study were susceptible to meropenem. And if we look at the distribution of MICs among these strains, you can see that the vast majority of strains had MICs that were 16 or greater. But there was a fairly large tail, or a number of strains, approximately 25 that had MICs of 8, another about 22 that had MICs of 4, and then there's this whole group of organisms that had MICs that were at or below either the CLSI or the UCAST carbapenem breakpoints. And we see variable levels of performance based upon the mechanism of resistance. So among KPCs, about 25% of the population that was enrolled in this study had a KPC that would be defined as being susceptible to meropenem. The story was even worse for OXA48-like organisms, with about 40% of all OXA48s that were enrolled in this study having an MIC that was less than the breakpoint included in the study. One standout group where we saw quite good performance was among the NDM or the New Delhi metallobeta-lactamase producing organisms, where 100% of these organisms expressed enough CRE resistance mechanism to be higher than the breakpoint for both CLSI and UCAST. So one of the reasons culture-based methods are challenged is largely because the MIC might in fact be below the breakpoint for that individual drug. So this leads us to ask the question, should, instead of doing culture-based approaches, should we be doing a mechanistic-based approach to look for the presence of carbapenem-producing organisms or to look for the presence of carbapenemases? So there are a number of technologies that will help you do this as well. And those range from very complex molecular approaches to very simple lateral flow approaches. This is a technology that we evaluated in our laboratory as a part of a clinical trial. This is the NG-CARBA5 assay. This can be used with both Enterobacterales and Pseudomonas aeruginosa, and can be used from colonies that are grown on either 5% sheep blood agar, MacConkey agar, or chromogenic media. This test detects the big 5 carbapenemases. These include KPC, OXA48, VIM, IMP, and NDM. And it will tell you which enzyme you may be encountering based upon the presence of a line. You have your control line telling you the test works, and then you have any of your other lines that are present indicating which carbapenemase may be present. Top line being KPC, then OXA, VIM, IMP, and NDM. So fairly easy to be read and can be done within about 15 minutes. So this gives the advantage of being available for not only labs that have highly complex molecular methods, but can also be done in community hospital laboratories that may not have a lot of those molecular methods. It's fast, it's reasonably comprehensive, and I'll show you some data on how well it performs. So in a study that was conducted at the Medical College of Wisconsin, as well as several other study sites, we looked at three different populations of organisms and tested the performance of the CARBA5 test. We looked at organisms that would be included in the Enterobacterales group, as well as organisms that could be included in the Pseudomonas aeruginosa group. And we also looked at a combination of Enterobacterales plus Pseudomonas aeruginosa. And you can see that among Enterobacterales, we looked at KPC, OXA48, VIM, IMP, and NDM, and we compared the performance of the lateral flow device to PCR and whole genome sequencing. So when we compared to PCR, we overall find 100% sensitivity, and our specificity ranges slightly based upon individual targets, where we see between 98 and 100% specificity, with the NG-CARBA5 test missing 3 IMPs, or having 3 false positive IMPs and 1 false positive NDM, Interestingly, on the imps, when we went back and sequenced those, several of these imps were actually imps that were not included in the molecular test that we use as the comparator method. The story for Pseudomonas was quite similar. We didn't look at OXA48 because OXA48 generally isn't present in Pseudomonas. We didn't have any NDMs that were included in our study, but overall among the KPCs, VIMs, and imps, we found quite good performance. And the 3 false positive imps that were present in Pseudomonas were all not present on the molecular method that we use as a comparator, but they were found using sequencing. So when we compare to sequencing, we find that the specificity is approaching 100%. And again, when we combine overall Enterobacterales plus Pseudomonas aeruginosa, our overall performance is 100% positive agreement and 95.1% negative agreement. So again, I mentioned to you a little bit earlier, when we did our comparison, we compared with the molecular expert CARBA-R assay. We did find that there were several IMP8s and IMP7s that were detected that were missed by the CARBA-5 or the CARBA-R assay because they're not present in the expert CARBA-R assay, but we were able to find them using our sequencing-based approach. So what about molecular approaches? There are a number of different molecular approaches that we can also think about for detecting the presence of carbapenemases. So one test being the expert CARBA-5 or the expert CARBA-R. This performance has been evaluated in numerous studies. I'll show you the data from Tato and colleagues, which cites sensitivity ranging from 93.5% to 100% and specificity ranging from 99.3% to 100%. And this test will detect the KPC enzyme, NDM enzyme, VIM, selective IMP enzymes, as well as OXA48. There are a number of other assays as well that can be done either in a batch-based format or that can be done on an on-demand basis. These include things like the BD Max, as well as RUO panels, as the one I've shown here, which can include things like KPC, NDM, VIM, IMP, OXA48, as well as a host of other mechanisms of resistance. And one of the key things that you have to consider as you evaluate which technology you're going to use, how fast do you need your results, how broad do you want to go, and what organism groups do you want to look for? Are you interested in just looking at Enterobacterales? Do you want to add Pseudomonas aeruginosa? Do you want to add Acinetobacter baumannii? Well, each of those decisions will prompt you to have to think about, does my test actually detect the carbapenemases that are present in those organisms, and how well does the test perform with those mechanisms? And then we also have to ask the question, why are we doing all of this? And is all of this justified? And there are a number of different reasons that we can think about that will help us to justify these approaches. Might be important for epidemiology, understanding what's circulating within your region, within your hospital system. It might help you to recognize potential outbreak a bit earlier. Increasingly, though, we are also seeing that the results of your carbapenemase test also may play a very important role in helping your providers select what treatment they're going to choose. Is this an enzyme that will allow them to treat with one of the novel beta-lactam/beta-lactamase inhibitors that have been recently cleared? In making the decision between, is this a metallo-beta-lactamase versus a serine protease? That can help us to make a decision, is this going to be a novel beta-lactam/beta-lactamase inhibitor that we're going to need to think about? Or do we need to think about something like Sofeticol, or think about something like Calista? So increasingly, not only are we seeing these tests useful from an epidemiological perspective, but in many cases, if we can identify the type of carbapenemase that's present, that may help our providers to better select what antimicrobials they want us to do susceptibility testing on, or what drugs might be applicable and what drugs may not be applicable. The final approach I want to mention today is also NGS. And there's been a lot of work that's been done looking at how can we improve NGS so that this could be used as a potential screening technique. This is one study published by Doyle and colleagues in the journal Microbial Genomics. And they looked at a number of important comparisons. First, they looked at how well can this test actually detect an individual resistance mechanism. And I don't expect that you're going to memorize this table that I'm showing here, but this nicely shows on a by mechanism basis how well sequencing performed when compared to phenotypic susceptibility testing. And they looked at this compared to using aminoglycosides, beta-lactams, quinolones, Bactrim, as well as a host of other antibiotics. One of the most interesting things that you can, or one of the most interesting conclusions that you can draw from this study is that when we look at performance of the beta-lactams, the comparison between sequencing and the phenotypic result was actually the best. Performance was a little bit worse with aminoglycosides. It's pretty awful with Bactrim. But at least for the beta-lactams, there was some fair degree of promise. This was similarly shown when they did a comparison between the phenotypic result and the sequencing interpreted result. And you'll see here, organisms that were determined to be resistant by phenotype, susceptible by sequencing, were at their lowest among the beta-lactam antibiotics, indicating the potential best level of performance. But the study also highlighted an important point. And you don't really need to understand which drugs were tested in order to look at this. This simply asks the question that for a number of different drug classes in over 9 laboratories that use different bioinformatic platforms, that use different sequencing-based approaches, but use the same isolate set, we still have a fair amount of diversity in performance, or a fair amount of difference in performance. And you'll see here for each of these drug class groups, you see more or less agreement between laboratories. So for the first 2 groups, you'll see there are several laboratories that identified a lot more antimicrobial resistance genes than other labs. For other compounds, we saw pretty good agreement. And then there were this was the Bactrim group, that you'll see pretty bad disagreement with many labs identifying more than 50 resistance genes and others showing less than 10. This is a real call for better standardization as we start to think more and more about the use of NGS-based approaches in screening and in diagnostics. We really need to look at how can we standardize our method-based approaches, as well as how do we standardize our bioinformatic pipelines so the results that come out of my laboratory are similar to the results that come out of your laboratories. So really interesting data showing a lot of promise, but also some opportunity for better standardization. The final area of my talk today that I also do want to draw your attention to is we've spent a lot of time talking about patient infections and patients as reservoirs of carbapenem resistance. In the last minute or two, I do want to point out to you, patients aren't the only reservoir of resistance. And this was nicely summarized in a study by Gordon and colleagues. They looked at 32 reported outbreaks of CRE, and they looked at what they were associated with, or what was the reservoir for the CRE. 17 of the 32 studies found drains or drainage systems to be the reservoir. 14 of the studies found sink surfaces to be the reservoir. 2 studies found water and tea dispensers to be the source of the reservoir of the CRE. And 2 studies also found the ubiquitous toilet brush to also be the reservoir for CRE in the study. The other thing they note in this study is it's not always Enterobacterales, it's not always CRE. We can see organisms like Pseudomonas, Acinetobacter, Serratia, E. coli, as well as a host of other organisms that can be affiliated with outbreaks where they have an environmental origin. So as we think about developing screening programs, about isolating patients, we also do need to take into consideration the environment and really make a determination of, is our environment also contaminated? With that, I'll summarize and I'll say There are a number of sensitive diagnostic tools that are available to detect and differentiate the common big five carbapenemases from both isolates and clinical specimens. It's also important to determine and separate carbapenemase producing organisms from non-carbapenemase producing carbapenem-resistant organisms. And the enzyme can play a very important role in determining what drugs we may want to consider for treating that infection. We also know that infection with CRE can result in mortality exceeding 50%. And this is really caused a significant public health crisis. We also know that isolating patients with known CRE can prevent the spread of CRE, but can also have a number of unintended consequences. And finally, the role of screening for CRE and the role of isolation continues to be under intense scrutiny and intense study as we continue to deal and encounter this significant public health crisis. With that, I'll thank you for your attention today.